NHS Direct board meeting of the calendar year. There will be a few thank yous and special messages, but I'll leave those till the end of the public meeting. We have apologies from Sue Hunt, who's got a family medical issue. Trevor will be, you'll be here for the whole of the board meeting, that's great.
On this public?
For the public meeting, that's great. Tim Hayman will be arriving a bit later. And as far as I know, Steve Duncan will arrive imminently. So we're close to having a full house. Just welcoming particularly anybody who is watching online, and may I ask you once again to be aware of the fact that it's just a meeting, it's not a performance, it's not scripted. There will be hiccups. We do our best with the quality. Please fill in evaluation forms when you come offline so that we can do it better in the future. Okay, I've had no declarations of interest with this particular agenda. Obviously people are free to declare interest later on if any occur to them. Are there any now? No? Okay. Let's then move to the minutes of our last meeting, which was held here on the 28th of November. Are there first any items of accuracy on those minutes? Tricia?
Not particularly accuracy, Chair, but I'd like to change at 4.2 the final sentence. I'd like it to read, within the 0845 service, callers were asked to consider contacting another health professional if all symptoms persist.
Okay, that makes sense. Anything else on that set of minutes?
No. Sorry, I had one question. I'm sorry because I wasn't at the meeting, and maybe somebody can fill me in offline. Just 5.3, I wasn't sure what this meant. The clinical input for the 1-1 service was the critical component.
And 5.3?
Yeah.
So what we were talking about here was the difference between the different pilots in terms of the proportion of patients that were referred on either by ambulance or by urgently to a primary care professional, and the critical components that determined whether that rate of referral was higher or lower was the degree of clinical involvement in calls. So
I thought that probably was what it meant, but then should it mean the? Okay, I think it just was. It's not.
The sentence needs to be linked.
Because what you mean is it's either the lack of clinical
or the
input in one service, or the fact there is some in the other.
Correct.
Okay. We also have, thanks to Keith, at the end of the minutes we have Keith's evaluation of the meeting last time. We got a bit squeezed at the end, so we weren't able to hear that in real time, but I'm sure everybody has read it and internalised it going forward. And I think, Trevor, are you evaluating this time around? Does anybody know if they're evaluating?
Happy to, Chair. Happy to.
Okay, great. Excellent. Fine then. Shall we, if there aren't any matters arising that aren't in the rest of the agenda, shall we move on to the action law?
Yep, there's actually nothing to raise, as the one item that's due on that hasn't already been reported on is on the agenda, which is the appointments line. Everything else is either in progress and will come to the relevant board meeting, or you have the note there that we have communicated on the North East and North West. Well done.
Great, so then list of things that I've been doing. Happy to take any questions on that. I suppose the one I would highlight particularly is the Cisco Public Services Summit, which I've sent a separate note around. Yeah. That was a very interesting event and exposed us to a lot of new and ideas about the way in which public services is developing around the world, so that was very interesting and useful. Okay. Roger.
Chair, can I ask if in any of the meetings, particularly with Stephen Dorrell, Francis Maud or the eHealth Insider Roundtable, to what extent 111 was a feature of those meetings and what were the themes?
It wasn't on the open data meeting, which is the last one on that list. That was much more about plans that are in progress for releasing data into the public domain and what that means. Okay. the main point of contention around that was the need for consistency, because there are still some bits of government that still make money out of making data public, or they sell data. Basically, there's an inconsistency around that. So that was sort of, there was a bit about 111 in the eHealth Insider roundtable, because that was a discussion about how will technology within the NHS be deployed in the coming year. Right. Much more there. I would say, Nick may have a different perspective, and others who are out and about might have a different perspective, but it is my experience that 111 is very rarely raised as an issue, except by me, in the events that I'm in. So my impression is that awareness at sort of in the arenas that I tend to be around is pretty low. People are interested, very interested, when you describe this important change that's happening to the NHS, but it doesn't come up spontaneously.
Okay. Yes, that was.
Took me a long time to get there, but I got
that was the sort of thing I was interested in. Right.
I think it's. I agree with you. I think it's regarded by many as a kind of specialist and rather uninteresting subject until people actually understand what it's about.
Well, I think what I'm finding is people just don't know about it. Really.
Yes. No, thank you. Interesting.
Okay. Shall we move on then? So we're now into the performance section of the report. It's quite interesting. I don't know. My engagements are obviously categorised differently from Nick's very important Chief Executive's report, which I'm sure is quite right. So in the first item in the performance section of the board agenda is your report.
Put your report in the performance section.
I think that would be a very bad idea. It's not.
Okay. Can I first correct? There's an error in the first item. South East Coast. The bid return date isn't the 31st of January. It's the 22nd of February. So apologies for that error. So I'm not going to go into any detail on either of the two 111 procurements that are talked about here. We will brief the board separately in the private part of the agenda for fairly obvious reasons of commercial confidentiality. However, I think it is fair to say in the public domain that the approach that we saw in the North East seems to be reflected largely in the tender proposals from South East Coast, and that is significant. But as I say, I'll simply flag that, and we'll have a further discussion in the private part of the meeting. Okay.
Right. Do you want to just take questions on it?
Yeah, very happy to take questions on that.
Does anyone? I've got a couple of questions. Anybody got any questions before I launch in?
Oh, sorry, these questions just about item 1, about the whole report.
No, whole report.
I've got one. Yeah.
Okay, Louisa, then Peter.
I'll have one in a moment.
Is it worth talking any more about the whole system demonstrator programme, which clearly will increasingly be a big plank of DOH strategy and our role in that?
Yeah, certainly. I think it might be helpful, because I also need to give a quick report on the Birmingham Own Health, and it's ironic to sort of link the two together, really. So first of all, if I can deal with Birmingham Own Health, and then I'll talk about the whole system demonstrator. So we have reached the end of the consultation period with staff employed by NHS Direct to provide the Birmingham Own Health service. As the board will know, the Birmingham PCTs, I'll just pause. The Birmingham PCTs are currently out to consultation on the cessation of the Birmingham Own Health service, and as a result of that have not renewed our contract which we hold together with Pfizer in Birmingham. This of course is for a remote service to support patients with long-term conditions, and therefore is slap bang in the middle of the message that comes out about the whole system demonstrator. So the irony of, on the one hand, having a major national push, which I'll say a little bit more in a second, around the use of telehealth and telecare to support patients, whilst at the same time one of the prime examples of where this has been taken on by a whole system in England is effectively being deprioritised. So the executive team considered the results of the Birmingham Own Health consultation and agreed to the proposals arising out of the consultation, which were to redeploy the staff with effect from the 31st of March to coincide with the conclusion of the tender. Of the contract. In terms of the whole system demonstrator programme, this is part of a broader report produced by Sir David Nicholson, to establish how the NHS can contribute more broadly to the economy through its approach to innovation. And one of the examples of that, one of the prime examples of that, is the use of telehealth and telecare. It's identified there are 3 million patients who could benefit from this, and given the approximate cost per annum of telehealth and telecare for a patient for a whole year is about £1,000. This report is in fact an exhortation for NHS commissioners to spend about £3 billion a year on telehealth and telecare. And what the report indicates is that there is an extremely compelling business case for those commissioners so to do. So we are seeking to be involved in promulgating our solutions to commissioners that will meet the needs that are identified in the report. And we have a small but perfectly formed team who've been working on our long-term conditions offer as part of the board strategy that the board approved about 9 months ago. So that's roughly where we are. I'm sure we will be able to bring more detail in terms of the engagement activities to the board in the future.
I just wanted to ask Nick about the innovation report. Has that been sent around to the board? Do we have I mean, presumably it's a long document.
Very happy to send the link round. I'm not sure if it has or not has been sent around or not. Apologies if it hasn't.
Have we got an internal digest of it or a key points document or something? That would be helpful. So perhaps we could have that and the link to the main report for anybody who's a real glutton for punishment.
Oh yeah, indeed.
So Louise, was that a follow-up? Or
It's
should I
just a
go
little
to Peter?
follow-up, and whenever people
Come
talk
to
about
Peter.
this, it's always about making sure that, which I know we all know, but just because I feel anxious about it, is that anything that we do should be substitutive and not additive. And just as well as engagement, it would be great to have some idea of how this sort of fits into workflow and how it isn't just an add-on.
Peter.
Yes. Can I just say how important I agree with the development of telehealth and telecare. And as an example of that, most local authorities, and West Sussex in particular, have been pushing this very hard. It comes on the back of mainly fairly elderly people to particularly look for support with not necessarily long-term conditions, but mobility problems and safety problems. Regarding dementia and supporting carers. So this is a very good initiative. What I would hope I could add to it by saying that it should be a whole system approach, which I think you were indicating it was.
Yeah.
And certainly in local government you'd find an open door to support this sort of initiative. As there are potentially significant savings for local government as much as the health system. And certainly in West Sussex and I think elsewhere, joint commissioning of these services is seen as the way forward. It's not just health and social care. It also comes alongside reablement programmes, which I think are an essential element of this as well, because they lead to making people as independent as possible if they can, but also a spin-off is obviously telehealth or care support in their own homes. But it does give a lot. I've certainly met people who've had these services And the key thing is they are confident people now about their particular concerns, but also their family or their immediate carer, particularly older carers, feel happy as well that they know what's going on. So I do think that's important. So well done. I think this is excellent initiative, and I hope it succeeds. That's all.
There was a remarkable example of that was showcased at this public services meeting I went to in Oslo, which was developed at the largest hospital in Denmark, which also happens to be the largest hospitals in the Nordics, and the CMO came to present it, and it involved something called a COPD briefcase. So they had a cadre of very frail patients who came in typically 5 to 10 times a year with COPD and stayed for 5 to 10 days, and they now get them out the day after. So they spend one night in hospital and they go home with a COPD briefcase, which is really simple. And although this patient group has a mortality rate of 36%, they've never had someone die at home as a result of this very early discharge. So I think it can be an extraordinarily powerful thing. Okay, I've got a question about the future workforce. I'm confused about, this is maybe a question for Keith, about your point 2 about the date, because I thought that the roster return date had moved forward and then back again. So I thought we were now at the 31st of December for people, so it won't be completed before Christmas.
Sorry, as when the paper was written, the date was 26th of December. We moved it back to the 31st.
So in discussion with the staff side, we moved it back to the 31st.
We moved it back.
Yeah.
Okay.
5 days.
All right, so we responded to staff side's
We did.
concern that we moved the date forward and it's gone back again. Okay, I think that's worth noting. Thank you. All right, Tim.
I think it's useful that Nick attached to his report the what happened on the 30th of November with the industrial action. I remember at the last board, Roger, you were describing various methods that we had for calling people in. This paper doesn't refer to that, so I assume we didn't have to take any of that extraordinary action that you had put in place.
No, but really due to the really good development of the relationship between management and staff side, we were able to have enough people. We were able to agree the number of people we needed in, and they came in.
Okay.
So I mean,
But no emergency action.
very good cooperation, no emergency action.
We were actually able to offer additional support to various ambulance trusts at points through the day. That's how well we coped with it.
That's very good. So I've got Louisa and Trevor Jones.
Well, it's only a quick question. I'm sorry, I should probably know this, but it's just really helpful when you say we answered 11,100 calls. It'd be nice to know what we normally do on a day. So more or
A
less,
normal weekday would be 8,000 to 9,000.
Okay, thanks. So then, and the same with the online health. So it's just interesting to know that.
Trevor.
It really refers to the comments Roger was making. I think we should record our thanks to the staff side for the very mature relationship we have with them and the sensible approach to the industrial action.
I totally agree. And it was precisely that which enabled us to provide this additional support to ambulance trusts. So I think our staff should feel very good about that. Great. Let's move on then into the performance package. Trevor, over to you.
Chair. Service headlines for the month include 343,000 patients and users of the core service. We also had 952,000 uses of our health and symptom checkers online, and our appointments line service received 247,000 calls in the month. Core service performance levels improved slightly. We performed well on access targets for the service, with 96% of users able to access the service within 60 seconds, and we had an abandonment rate of just 0.9%. That's significantly better than planned. Clinical assessment for the most urgent of patients remained well within target, but we were below target for both less and non-urgent calls. Our patient satisfaction levels remained good at 92%, and complaints were just 0.3 per 10,000 calls. I'll pause there and see if anyone wants to ask any questions around service levels before I discuss our financial affairs.
Trevor Jones, then Tim, then Peter.
One small one, please.
Generally, I'm pleased with the way performance is improving across the board. The question I've got is about the expert call review, where we are only at 65%.
at the end of November. In the Clinical Governance Committee, we were expecting the target to be achieved in December. I really want confirmation that that is still the case, if that's possible.
Tricia.
Yeah, thank you, Chair. We're still striving towards that target, and some of the new recruits into the service and issues with managing those staff and not being able to deliver the timely feedback to individuals at the front line has impacted in the core review scoring. We are also, for the board's information, reviewing the whole process once again in line with the RCGP tool, which will be used as the benchmark in the 111 service. Within that tool, the scoring is at 61% or above for a good and satisfactory service, and we've met that target throughout the whole of the year. So we are doing a look-back exercise at the scoring within our core review tool and making appropriate amendments to bring us in line with that scoring.
Okay. Jeremy, do you want to come back on that?
Yeah, I'm not sure I fully understood what you said there, Trish. We had a target of 80% as our performance target.
Yeah.
At the end of November, we were 65%. It sounded in the end of what you said as though the action was to reduce the target, not to improve performance.
No, we are striving to improve performance. What we have done is there is some scoring elements which are not in relation to the patient safety elements, but reflect the empathy and the smaller points of accuracy within the core review process, which when add up significantly drop the scoring from what would be a good satisfactory call and tip the balance from an excellent call to good satisfactory, and we're actually trying to revise that scoring in that we don't overly penalise our staff when they deliver a safe and a high standard call. At the moment the scoring makes it tick over into good satisfactory, and we're trying to reflect that they are actually delivering an excellent call to the service. Our scoring is not quite in tune.
I would like to ask the Clinical Governance Committee to have another look at that. I'm not sure I'm comfortable with that as an approach going forward. Peter, you want to build on those? Thanks, Trish.
Have a raised point past what I was going to say. What I was just concerned about was the ability for staff to properly have time off or time out to do this work, and for it to be sustainable in the new rostering arrangements. And I just think that might be worth keeping an eye on as well, because just in the narrative it talks about the need to maintain and assist in the achieving of this KPI, and so that sort of builds on what Trevor has just indicated. Can we get there, as it were? And I think that if the Clinical Governance Committee is going to look at it, then the sustainability of it should be part of that as well.
Okay, so Tim, I haven't forgotten about you. Roger, you want to... it's a new point, is it? Okay.
No, it's not a new point. It's really...
Oh, well, then let's go to Roger.
Just to say, Chair, that all of this sort of activity should be far more sustainable under the new rostering regime, because the staffing will be more even throughout the week. At the moment, it's out of hours and at weekend are just the times when we're not able to get enough people offline in order to do this sort of work. So one of the principal reasons behind it should be easier. It should be easier.
Thank you, Roger. That's encouraging. We will no doubt see whether that is the case.
Well, put your head over the parapet.
I'm sure you will.
Thank you.
A spike, did you say?
Well, one of my questions has been dealt with. Thank you, Trevor. That was one. The second one, on page 7 of 12, and we're looking at... I was a bit pulled by some of this, because the lower two charts have quite a compressed axis, but the top one, 111 calls not requiring onward referral, it's been knocking around 20% for July to October, and then November it seems to have jumped to 28. Looks like 28%. That's quite a big jump. Is that significant? Has something happened to make that happen, or?
I don't believe it has. I think it's just As you say, it's quite a condensed scale, so I think there's only a few percent, but I'm not aware of anything that's driving that.
Okay. Well, maybe we'll look at that. We should look at that again next month.
We'll take an action to investigate that.
Yeah. Thank you.
That makes sense to me, given how very important that is for the impact of 111 across the system and potentially for our own bid's success. Okay, very good. Roger.
Can I just, without wanting to make another hostage to fortune, can I just point out something about sickness that you may not have noticed in the board report, and that is that if you look at the sickness graph on page 9, you'll see that relative to last year, our traditional increase in sickness through the autumn is nothing like as steep as it has been. And I would just like to commend staff and managers, particularly as with things like the rostering consultation, we're not going through a particularly easy time in terms of things like employee relations at the moment, and that over the last 4 weeks, up to a week last Friday, that improvement has continued. And as I said, Chair, I would not like to make myself a hostage to fortune at this time of year, because we have seen some spectacular rises in the class, but I would like to commend both colleagues at the front line and their managers for the really hard work they're continuing to do to keep sickness levels relatively low.
Okay, thank
We're a
you.
long way away from our target, but relative to last year, they are low.
I wonder,
Thank you.
Nick, when do you think would be a good time just to ask Keith perhaps to talk about preparations for Christmas?
Well, now seems like a good time. Yeah.
Okay, so I mean, I suppose.
Is that my first hospital?
That wasn't delivery.
We're talking about performance. It seems the relevant time to just to have a quick resume of where we think we're at as far as Christmas
planning is concerned. We've been very conscious of the graph on page 5, the top graph on page 5. And what happened last December?
Very cold last December.
It was very cold last
Yes,
December.
it was a very early winter last December.
So Keith, just I mean, obviously, the Christmas holiday period is traditionally one when a lot of people rely on NHS Direct because other services are closed. It's a place with very high demands on our service. It's obviously something you've been thinking about. Just tell us a bit about how you think things are going to go.
So, in terms of health advisors, we've increased the conduit call-off, and they have been working to recruit and train their people, and that call-off takes effect from that increased call-off takes effect from today. With regards to nurse advisors, we have approximately 125 whole-time equivalent nurses who have been in training since November. They go live today. Boxing Day is traditionally our busiest day. We think, however, this year the 27th will be our busiest day because that is also a bank holiday. Christmas Day is looking fine in terms of staffing. Boxing Day and the 27th, there are pockets where we've not managed to get to the staffing levels that we were hoping to get to. We are recruiting from a fairly limited pool of qualified nurse advisors, so we haven't been able to reach exactly the target that we wanted to in terms of nurses. Broadly, again, in terms of running an operation, you wouldn't recruit just for 1 or 2 days of spikes anyway. So what we've tried to do, rather than just staffing for a 2-day spike, we've tried to smooth that across a 12, 13, 14-day period to give us a smoother call journey as we can get to.
Fine, thanks very much indeed. Okay, shall we then move on into finance? Trevor?
Sure. Our financial performance on income and expenditure remains on target for the year to date with a surplus of £1.1 million. We currently have a cash balance of £22 million and we've invested £1.8 million in capital for the year to date. We continue to closely track and manage risks in order to deliver our forecast targets for outturn this year. Happy to take any questions on the report.
Any questions on finance? Tim.
Trevor, I was looking on page 5 again, of the appointments line, which is showing a kick up to the year end, where we've had a trend all through, a falling trend all through the year. Is that plan real? Do we think it's going to happen?
I haven't got the exact details behind how we're going to stimulate that level of activity, Tim, but it is an operationally forecast activity level.
Yeah.
So I will come back to you outside of the meeting with some drivers behind that.
It doesn't look as though the year end's achievable.
Volume.
Yeah. If you look at the top chart or the income chart, it doesn't matter which. They're showing a kick up. They've showed a steady decline throughout the year, and then a kick up for the last 4 months.
So I'm sorry, Tim, I haven't got the drivers down here, but we'll pick those up for you
Okay, thanks,
and circulate those around to members.
It's important for our year-end forecasting.
Yes, indeed, yeah.
Trevor.
I'm looking at paragraph 4.2 about frontline staffing. And I'm struggling a wee bit with the explanation of the change in quarter 4. It says that staffing levels are closer to the budget because of additional winter pressures activity and 111 pilots.
Yeah.
Keith.
Could I answer that?
Yeah.
We've been running for much of the year at below required numbers for nurse advisors because there wasn't recruitment activity going on for the first 9 months of the year. So we've been underspent on nurse advisors for a large part of the year. So we've now, as I just mentioned, got 125 whole-time equivalent, which is about 210 heads actually coming on live. So we now have that expenditure. So the gap between what we were planning to spend and what we're actually going to spend is narrowing.
I understand that. What I don't understand is linking that to additional winter pressure, because I would have thought the quarter to date in terms of winter hasn't been any different to a typical year, and compared to last year, the winter pressure has been significantly less to date. So I wouldn't have thought we would be staffing up for additional winter pressure in that quarter to date.
Depends what you mean by additional. I don't think it's
Well,
additional compared to last year's.
No, it's not additional compared to last year. It's additional to what we would.
But would we not just build that into a profile budget anyway?
That's what you're going to. Sorry. Sure. That's what you're going to do, isn't it? Because at the moment it's a 1/12 budget, isn't it?
Is it a 1/12?
This is connected to the additional funding that we received from East of England during the course of this year. So it wasn't within the original opening budget. We've received additional funds and we've contributed to our own internal funds to that. So we've put together basically the battle fund for winter pressures
So
of
it's really
£2.9
about
million.
additional funding.
Yes.
It's not about additional winter
I think
pressure.
it is.
Yes,
Not that
absolutely,
makes
yes.
sense.
Yeah,
That
I
makes
think
sense.
that's a good point.
Okay. Anything else?
That's good figures.
All right. Let's move on then to the corporate risk register. Helen, would you like to introduce it? Does that make sense?
Yeah.
Yeah, that's fine. There's 4 items on the risk register that were on there last month, and we've actually discussed 2 of them in that Roger said about sickness, and our November figures are steady at just below 7%. We've already discussed about rostering arrangements, and there's the ongoing effects with engagement with staff. There's no change in the risk rating relating to duty to break even, and actions are ongoing and monitored and reviewed monthly. And with regard to industrial action, we've decided to keep this on the risk register, and it's decreased from 12 to 9, but there is the potential of further industrial action in the new year. And that's it really.
Does anybody have any comments on the risk register? Okay, well, I do. I think we've improved this process tremendously. I think that the amount of red on the risk register is huge. It's huge. What that reflects is the environment in which we're working. And it seems to me that we're doing everything we can against those, but they won't go away. If anything, they'll intensify. So it's red's a nice Christmassy colour. It's not what we want to see. but it is an artefact of the business environment rather than something driven by our own organisation.
Right.
Thank you, Helen. Okay, so we're now into the strategy section of the agenda, and the only item, and it's a significant item in this section, is the consultation, the second element of that, as it affects our colleagues who run the appointments line. Keith.
Okay, so this paper builds on the board seminar and the previous board meeting in November, where we agreed to implement the recommendations and proposals from our future workforce consultation. The specific driver of proposals for TAL is the need to prepare for a different operating model where we can deploy frontline staff with greater flexibility across service lines. And what we're also proposing to do is rationalise our use of agency staff. So we're proposing to move more towards the call-off model that we use on core. Currently, so a number that members will be familiar with from the previous consultation is the concept of roster efficiency. At TAL we are currently on 80%. These proposals get us to about 94%. So significantly higher than the proposals for our main workforce. That's partly because the change is not so great, because most of the staff on TAL already operate on a rolling shift pattern. So they're used to the concept of not having fixed shifts. That saves us around about £420,000 per year, of which about £150,000 per year will be the impact of rationalising the use of agency staff. The detail provided to the board in November is applicable to TAL, so that's not replicated here. They're proposed to. There were three main areas specific to the TAL consultation. One was regarding the need for greater choice, and this has been accommodated. One was regarding the retention of a 22.5-hour week, i.e. 3 7.5-hour shifts option, and as with the core service, that has been agreed as well. And another area of contention with staff side was regarding a retention of a 6-hour shift, and that has not been recommended. So we're recommending 5 or 7.5-hour shifts. The appointments line demand is also slightly different in that it only warrants a 2 weekends in 8 pattern, as it only operates from 8 till 8 Monday to Friday, and also in terms of its call profile, Monday is by far the busiest week, which isn't the case for core.
It's a stupid question here, but how is that a weekend? If it's Monday to Friday?
It's definition of a weekend, I believe, because they do work into Friday evening.
Okay. I just want to welcome Mike Daly, who has arrived more or less precisely the right time, because we're just talking about the TAL consultation.
In terms of the consultation itself, there were 13 roadshow events convened. There were 74 one-to-ones. 126 staff attended the roadshow events, and 87% of staff had a one-to-one. And again, one-to-ones were offered to all affected staff, and the proposals affect a head count of 85 and a whole time equivalent of 72 TAL call handlers. So again, to summarise the key issues arising from the consultation, first one at 4.2.1 is that choice should be built into the proposed options. A work pattern choice has been built into the shift design, which is at Appendix B, and that gives the staff a choice of 3 shift patterns for each contractual hours option. The second one was to keep the 22.5 hours, and as I said before, we've retained that. And another issue arising was the issue of 6-hour shifts, which we believe degrades the efficiency too greatly. There are 8 staff affected by that decision to remove the 6-hour shift. The main principles of the recommendation are maintaining a 2 to 8 requirement for weekend working, but retaining flexibility to adapt as the market changes. And also, back to the point you raised about weekend working, we are looking at blending TAL into the core service. which helps us with our efficiency. We're also looking to prioritise the deployment of substantive staff within TAL, and therefore deploy the agency staff in a similar way to which we use our other in-source providers. As with the core recommendations from the previous board, we are recommending a minimum of 3 working days per week, and contracted hours will be as with the main recommendations, and all variants under 15 hours will be discontinued. As I mentioned before, with TAL, most staff are fully flexible, so all staff will remain fully flexible with no preset shift start or end times, and each of the 5 roster patterns has 3 options within it, so that staff can exercise a choice of work patterns. And those are the key recommendations. The proposed rosters are at option B. In terms of the implementation timetable, Annex A, that will in due course merge into the same implementation timetable that we have for the wider staff consultation.
All right, thank you very much indeed, Keith. I'm just going to throw it open in a second, but just to before I do that, so my understanding is we're basically we approach this for the same reasons that we needed to consult with all of our staff to make sure that we're able to staff up for demand as we need it and are cost effective and have efficient rosters. We've applied the same principles as we did last time around, and we've had a similar sort of constructive engagement through the process with staff both collectively and individually. It's all is very important. I noticed that there's nobody from staff side sort of formally here. Roger, I wonder if you could just give us a feel for where staff are on this before the board, before I take any other comments from the questions.
Yes,
from the board.
we discussed this at the National Joint Partnership Forum last Thursday, actually, and staff side confirmed there that they weren't going to be here today and didn't want to add anything to the paper. I think just to give a flavour of the consultation in relation to the consultation meetings we have, I think in the early weeks of the consultation, I think there were some real questions about why the appointments line was included in the wider consultation, and we worked through those quite methodically with staff side colleagues, and I think ultimately they accepted that we needed to develop the same sorts of flexibility for TAL as we did for the rest of the service. And whilst the changes for TAL will not be as great as we go through the implementation phase, it does give us the flexibility to blend with the core service, and also, if necessary, to bring other of the smaller services into a kind of business service centre, which includes TAL and other services. So I think they accepted that ultimately.
Thank you. Peter.
Yes, thank you. Just a couple of points. One thing I just wanted to say, when I've been out there talking to staff, the TAL staff have been particularly indicating to me that they were keen to get involved in the mainstream of the core services. And although this might not be the way they might have wanted it to have occurred, I can see that there are some advantages in that having happened. So I just wanted to say that as part of my feedback, as it were, from the staff who I met some while ago now, but still that's still current, I think. Can I just check then on the implementation plan? Is it 2 projects, sort of streaming to as separate entities, or will it be one implementation plan for all the groups? Because I see you've got a staff rep again. Is that the same staff rep that we're talking about for the core, or is there another one that's going to deal with the TAL people?
It's the same one, yeah.
Right, okay.
So there is a lag because they're a month behind, but there will be a catch-up.
So it's one project, one process, as it were. Thank you.
And the objective is to align the 2 timetables.
Yeah.
I think that's to be applauded, because it would be a nightmare to have separate streams.
They can't start together because the core staff are already going through their selection, but they will. TAL will catch up.
And I only had one more small point. This was the point you made about 94% efficiency as against 90% efficiency. I know there are different services.
Yes.
Is there anything significant in that at all, other than, I mean, they're different numbers, but you did say last time we wouldn't go to 95.
Yes.
I just remember that comment. So perhaps you could say something about
the reason
why 94% is okay.
Yes. So as I said before, 95% would be perfect world. 90% is a minimum. These proposals for the appointments line do get us to 94. The main reason for it is because they are rolling shifts, not fixed shifts. That's the main difference.
Okay.
But the TAL staff currently work burdens of rolling shifts, so their efficiency is already higher. So we still achieve a 15%, but we go from 80 to 94 rather than 76 to 90.
Thank you for that clarification. Yeah.
Good. That's fantastic. Nick?
Just want to make one point that's relevant to the implementation activity, which is, of course, that is dependent entirely upon the agreement of an extension of the TAL contract, which, as things speak, as we speak today, ends on the 31st March this year. So we are awaiting a decision by NHS Midlands and East to renew and extend the contract.
Keith, sorry.
So we've referred previously to the collective consultation group at which staff side have attended. That's now been superseded, so we now have a project implementation board, the first of which was last Wednesday, and we have 2 staff side representatives from that, and that's going to meet fortnightly.
Very good. Okay, fantastic. Trevor?
Can I pick up a point from what Nick's just said? Contract has an end date of 31st of March. No decision taken yet, so presumably no decision until early in the new year at the earliest, based on where we are. What is the lead time from a decision to not extend the contract for us to actually terminate the service effectively? It just seems very close to an end date, not to know our future.
Indeed. I won't go into the details, but there are termination provisions within the existing contract, the existing TAL contract, that means that the financial consequences of how can I put it, a late decision to terminate the service would actually rebound upon the Commissioner. The reality, of course, is that unless a decision is taken to switch off the choose-book system, this contract will be renewed. So I think it's a relatively low risk. We are in consultation with liaison with NHS Midlands and East Group. Might have a bit more detail to add, but we're nearly there in terms of agreement. We're just waiting for the ink to be put on the piece of paper.
I would expect confirmation this week, subject to just further clarification on 2 points.
Okay, that's reassuring. All right.
Additional comment. I mean, I think it's terrific that 87% had one-to-one discussions, and previously we had the rostering consultation, and us non-execs were involved in that. Have we? That's a terrific input to our workforce, and I think that's terrific because one reason that I don't think there will be much misunderstanding around the patch of the business situation that we're in, which is useful. But the other thing is, I'm sure all sorts of comments were made in those consultations, and I wonder whether we've gathered all the other comments together and get some feedback. I don't know whether we have or not, and it might be worth thinking about if we've got some sort of record, because the investment that we've put into staff consultation in the last few months is quite high, and getting whatever other output out of it will be quite a useful thing to do. I'm
aware that every question that was asked by a member of staff was logged, and answers were given either generically or individually. I'm not aware of when that's held centrally, so I will take that action.
There may be some issues there that we need to pick up, and so I think it's worth putting a little bit of time into having a look at that.
Yes, I think lessons learned are always important.
Thank you, Tim. Trevor?
Another question, Chair, just to emphasise that improvements in roster efficiency of up to 94% are very significant, and will have very positive benefits for performance levels, user experience, and importantly around the efficiency level, and enabling us to deliver on an NHS national efficiency target of around 4% per annum. So this will be a major strand of enabling us to deliver that target.
It's a good point to end on, Joe. I think that's exactly right. So my sense of where the board is we recognise that this is a very important thing to do. We've done what we can to balance off the requirements of the service, the patient, the NHS, and the needs of staff. We've reached a conclusion, and we're ready to sign this off. Is there anything other than that? Okay, so the board approves this. Thank you very much, Keith, and thank you to Mike and to everybody who's worked on this, and to the staff who've participated. Thank you. All right. So we're now into the governance and compliance part of the agenda. My suggestion would be that we might do that, then take a 5-minute break. Thank you, Mike. I've also recollected, to my shame, that I think Steve Duncan did tell me that he wasn't able to come today, so I'm sorry about that. I should have remembered it. Okay, so under the governance and compliance section, we've got some minutes from the Clinical Governance Committee. Trish, are you going to present these in Sue's absence? I mean, we have talked about this meeting. That's for the record.
Yeah, Duncan fed them back last board meeting, and these are for the record, Chair.
Fine. So we've just got some minutes of the record. We don't expect to have any particular questions on those.
We use the opportunity just to ask Tricia just to very quickly update the board on the routine visit of the CQC.
Yes.
Just as it comes under the clinical governance heading, I thought that was a good opportunity.
Yes, thank you, Nick. The CQC undertook an unannounced visit last week before, and last Friday, visiting our Wakefield site. Staff received them at 9 a.m. and gave open access to the contact centre and to staff. One member of the CQC sat alongside our staff and listened into the calls for the whole of the visit, and contacted some patients having consent been gained during the call, and rang the patients back to discuss their experience, of which we haven't had any formal feedback on yet. And the other member of staff met with line managers. The Vera Savignani, the HR manager, facilitated various staff members participating in that. Mental health, children's services and clinical governance leads assisted with it. And there was a further visit last week to our Milton Keynes site, where the CQC assessor met again with members of staff and undertook some questioning, and on that occasion did not listen into calls. We anticipate there will be a further visit somewhere within the organisation, though that's not been confirmed, and there is a planned visit to our headquarters on the 9th of January for what we believe will be further questioning and some informal feedback. The formal report we will receive at the end of January.
Right. Well, I think, thank you for that, Trish. I think the board would want to formally welcome the unannounced visits of the CQC. We're obviously delighted for any activity which improves the quality of what we provide, and gives us food for thought and gives us external assurance about what we're doing. So I think this is a very good thing to have happened. And we want to thank the staff who've responded to it. I have a question. I mean, given that we are a unique service, I mean, we have lots of similarities to other things that are going on, but how well do you feel the individuals who came to look at our service really understood what we do? Because that's quite a challenge, isn't it? I mean, did they?
Yes, it is a challenge, and there was a general understanding of the service we provide. However, our clinical governance, David Ford, the Associate Director of Clinical Governance, took the opportunity to give further information, as did the other senior managers, when it was evident there was some slight misunderstanding in how the service is delivered.
So does that particular inspection team have special understanding or specialise in remote health advice and assessment, or do they just deal with any kind of NHS organisations, acute trusts, mental health trusts, community services?
They do cover the broad spectrum of health services. However, a dedicated team has been assigned to undertake our assessment, so we've been taking measures to inform them of the difficulties or the nuances of the service that we provide, so to help them inform.
So they didn't come with any special
No.
understanding
No.
or any specialised knowledge of the business that we're in, as it were?
No.
Okay, I think it's interesting. Thank you very much. We look forward to the report when it comes out.
Indeed.
Very good. Okay, I suggest we take a short break. I'm looking at the clock and tempted to say back at 5:30, but I'm not going to do that. And Trevor will. Yes. Okay. So actually, could we come back, please, at 20 to 12? Would that be all right? Welcome back to the board. Okay, so we've got a long way through our public agenda. We're now at the final section, which is stakeholder engagement. And the first part of that, which we deferred from last time actually, because of our time pressure, was a report back from members of the board who've been out and about meeting with staff and engaging with the front line. So Tim's not here to report on his Beckenham visit. Did he go solo or was someone there with him? No, it went on his own. Okay, haven't got that one then. Trevor and Alan, I gather you have been in Exeter.
And Alan will feed back, I think.
Yes, that's correct, Chair. Trevor and I went to Exeter on the 20th of October, on a Thursday. Very pleasant, compact site, very sort of workmanlike, businesslike site with pot plants and that sort of thing. It was about a third full. Felt it might be a bit noisy when it's completely full. And we had one-on-one conversations with 4 members of staff, 2 team leaders, one of whom has particular responsibility for home workers, and one of whom had just recently joined the organisation from the police force. We also had a teleconference with a home worker, one of the ex-Plymouth home workers, and we also had a long we had quite a long conversation with a 111 call handler prior to listening to a single 111 call. And then finally we had a one-on-one conversation with the regional head of business development. Main feedback from the team managers was around the management of staff. We focused particularly on 2 things really. One was feedback about the consultation and their view on the process. I think generally a sense of their understanding the need, sense that the management case had been well presented. I think they were at the time feeling a bit of a lack of clarity on the end-to-end process and exactly when things were going to happen, when what was going to happen. Fairly sanguine about the outcome, with a few specific points of feedback, I think, which we've heard previously. Interesting to talk to the team manager who recently came in from the police force. Has 21 in his team, feels he's able to manage that okay. Very important to be organised and sort of keep on top of who they're seeing when. And he has has 3 home workers in his team, but a significant number of nurses, about 18 nurses in his team, and felt that he was well able to manage the overall load, but also that there were no issues in managing the nurses at all. Moving on then to the teleconference with the home worker, and this was reinforced some of the things that the team leader had said. Quite a few technical issues with home working in the ex-Plymouth staff, calls dropping out, issues with latency of the application, and they're now in the situation down there where they're using a sort of hybrid solution which means that the team leaders don't have visibility of the stats, so it's quite hard to manage them. Significant positives were reduction in fuel bill, easier to start early shifts, and also to take ad hoc shifts as and when necessary. Believe they provide an equally valuable service remotely, but I think some of the negatives were feeling of it being quite isolating. Nice to have group meetings, but there'd been about 3 or 4 in all, but they hadn't taken place for some while. I think so. They were missing colleagues, and also a little bit of a sense of sort of cabin fever, I think is how it was reported to us. So I think the main sort of the main issue there was the sort of technical issues, though, as much as anything, I think. Had a long conversation with the 111 call handler, because we had to wait quite a long time for a 111 call to arrive, and a real sense of that the call handler welcomed the new service, thoroughly enjoyed it, felt that their responsibility had increased, that they were sort of given more sort of authority to be participating in the clinical service. And then when a 111 call did come in, it actually turned out to be a very complex call, and I thought she handled it absolutely brilliantly. Quite such an accomplished sort of handling of quite a difficult case. It was quite remarkable. I think Trevor and I were both struck that the clinical content seemed quite wordy and quite technical. Using some terminology I don't think which many people would necessarily understand, but it didn't seem to be a problem for the service user. We finished our visit there with a long conversation with the regional head of business development, heard a lot about the upcoming 111 procurement there, and I think particularly drilled down into the sort of fairly complex nature of it. It's a very large area and a very diverse area in terms of the sort of geographic spread, and also the nature of the obvious partner organisations across the patch, and quite a distinction sort of politically between the sort of the Gloucestershire-Wiltshire axis, and also then the sort of Bristol, Somerset, Devon, Cornwall axis, and a sense that contemplating partnering with the same organisation across the patch really didn't make any real sense. Trevor, anything you'd like to add to that at all?
Just a couple of things. A very, very positive visit. On the technical content issue, I think it's a fascinating issue. One of the questions for our patient, our client, was, have you ever had an aneurysm? And the patient, without moving, and this was the question coming on the screen, it wasn't the call handler, it was the question to be asked. The patient immediately says no, and you move on. When I raised it with our call handler, her view was anybody who'd had an aneurysm would know they had. Now, I personally am not sure that's the case necessarily. So I've no idea whether other examples exist in our system like that, or in the system, this is the pathway system, where there's an assumption that patients understand what I believe are technical medical terms for conditions. But I just pinned that to the wall, because the answer was interesting. If you had an aneurysm, you would know, because the doctors would have talked to you about your aneurysm, but I was left feeling a wee bit uneasy about that. Another issue which I found fascinating, we waited an awful long time before a 111 call came in. When the call came in, it was a patient who had an existing condition, was under the care of her GP. The condition was reoccurring, so she wanted to contact the GP again. But when she rang the GP practice, she had heard from the recorded message that the practice was closed. This was lunchtime on a Thursday, between 1 and 2 o'clock probably, I think. The practice is closed. Ring 111. Call came through to our call handler, who handled it very well. The call handler believed that the patient needed to see the GP. The call handler rang the GP practice, phone answered quickly, and call handler organises a slot for the patient, rings the patient back to say, go to your GP. I was surprised at that, to hear that a GP practice was closed on a Thursday lunchtime. But certainly interesting that a GP practice appeared closed. We discussed it with a couple of others in the call centre, just because I was surprised at this message, and we're told this is a regular thing that happens. You get a message which says GP practice is closed. If you stay on the line long enough, you will find that right at the end of the message it says, but if you have an urgent condition, ring this number, and you then get through to the practice and you could arrange an appointment. But most people have simply heard practice closed, ring 111. Now it struck me that that's something that isn't a particularly satisfactory response for patients. Interestingly, anyone who saw the national news this morning, it was a review of out-of-hours services, and it just struck me that some of these issues are appearing in that review as well. But it's interesting that inappropriate calls coming to 111 simply because of a barrier being put up to get into the primary care system direct. Quite an interesting call.
Very interesting. Does Roger and I have also been out on a 111 expedition.
We have.
So maybe, Roger, we should talk a bit about that, and then we might have a conversation around it, if that makes sense. Shall I
You go.
So Roger and I went to Nottingham on the 6th of December. We listened to some calls, and we also met the GP who chairs the clinical governance group for yes, and that was extremely interesting. So talk about that bit first. I mean, she was extremely complimentary. It was very rewarding to hear her talk about her view of NHS Direct and our contribution to 111. I was surprised. I was very surprised at her description of the clinical governance arrangements around 111. So that my understanding is that the clinical governance around those pilots is about the best developed in the system. Having said that, she said we were the only organisation who came to those meetings who came with reports, and that they rarely got a GP to come along. So it struck me that the rigour with which they were able to undertake clinical governance of the service was somewhat below certainly what I was expecting. Ruth also said, maybe it links to Roger's comment earlier, that she thought 111 was a huge revolution for the NHS, and it was really significant. Yeah. It was a really significant change. Yeah. So I thought that was interesting.
But she felt that was not shared by many other people.
Yeah, not really understood. Yeah. I'm just struggling to find my notes actually. So we then went and listened to some 111 calls. I think we heard 6, of which 4 were definitely misfires. Yeah. So they were people trying to get through to the surgery who did not want a clinical assessment. They didn't want a 111 service. They wanted to either talk to the doctor or they wanted to change an appointment. And we also sat around for quite a long time waiting for calls. The 2 real calls that required a clinical assessment were both complicated and both very difficult. Yeah. And I'm not sure how successfully they were handled. I think it was a bit of a mixed bag, to be honest. But it certainly showed, for me, the message, the top line message I came away with was how even in an area where the pilot is regarded as very successful and is up and running and clinical governance is functioning well, how very embryonic that feels, how underdeveloped, how early we are in the understanding of how to make that service work, and how to govern it effectively. So that was, I suppose, my the strongest impression I came away with was lots of potential in 111, but goodness, it's very, very early days.
Yes.
Roger, is there anything you want
Yes,
to
no, I mean, I actually thought the call handler handled those 2 very difficult calls in the circumstances extremely well, but it felt to me like he was doing a bit of learning as he went along as well.
Okay. Is there anything else anybody wants to contribute around those calls, or shall we move on to our patient experience paper?
Anybody else, did you notice anything about the language that was used?
No, I didn't. I have some other comments which I'm going to share in slightly different context.
Before we move on, I mean, the home worker point coming from Exeter, I think needs picking up to make sure that we've got the right support. I can't recall how many home workers we've got now.
About 100.
We've got about 100, and if they're all feeling isolated, and we need to think about that.
Yeah, I mean very deeply, because it will be our proposal that in order to get down to the number of sites that are going to be economic for the plan A1, A2 or A3 model, we will have significantly more home workers than we have now. And certainly it's my own view at the moment that actually they need to have their own division so that all home workers are working in the same way. Now, we're doing some intensive work over the next few weeks on developing the model for home working, and because it is a very significant element of the design blueprint for the new organisation. Very significant.
Okay, thank you, Roger. So more work to be done. Trevor?
I was just thinking about all home workers in the same division. That potentially, I'll just pin that on the wall, would make it more difficult for regular team meetings. What I heard from the person in Plymouth was, we have home workers around Plymouth and we don't get together, and we should. It would be good if we did. So division's fine, but what I wouldn't want to do is make it even more difficult for groups to come together. It doesn't have to be a whole division. But the interesting thing, all this person wanted was once a month, once a quarter, to meet her colleagues and have a chat about what life's like and how the world is moving forward.
On the contrary, Trevor, I think by having one division, what you're then doing is devoting yourself as a management team to home working and ensuring that the right level of support, supervision, technical support is all there, whereas at the moment these people are tagged on to the end of a team or a group or a division, and that is what is making it unsatisfactory at the moment. So early days, I'm not saying that that's the conclusion we come to. What I'm saying is we're really taking this stuff seriously, and we have proved that we can do it, but we're not doing it well at the moment.
Okay, thank you, Roger. We won't push that too hard now, because obviously you're thinking about it. Trish and then Brian.
Just a final comment, Chair. I have made links with some remote nursing services within Australia, and they've described very similar experiences. They have a service which is provided completely remotely. They have no bricks and mortar, and I think it would be worth us re-engaging with them and learning some of the lessons from them, how they have the remote team building.
Very good, thank you. Brian?
Sorry, I meant to say something just in terms of the language. That's a totally inappropriate question to be asking a patient. It's kind of meaningless from a clinical point of view. And what one should normally do in those circumstances, try to identify the symptom with which the patient falls so that we can feed it back to the clinical content team. Because asking someone if they had an aneurysm doesn't, did they suffer a burst aneurysm? Was there a problem because of it? So it's totally
I would stress that was part of pathways we were looking at.
But
the way our staff were responding using what was on the screen. But
it's quite appropriate for us to feedback on pathways,
absolutely
clinical content, and we're quite happy to change it. You have to spot it though.
Absolutely right.
Okay, good, thank you. Let's move on then to talk about the patient experience. Trish, do you want to introduce this very briefly?
Yes.
Because I think there are probably going to be some comments on it.
Yes. Okay. Thank you, Chair. This paper was gathered together by Mike Besant, the Regional Mental Health Lead in the South West, and I think the paper shows how NHS Direct plays its part in multi-agency working, and particularly collaborating with those agencies in managing patients who are high users of various services, both from NHS and third sector. This case alone demonstrates how we have supported the PCT and those agencies in bringing a formalised action action plan on us sharing the risks in managing a patient who had, as the paper identifies, quite a substantial impact on emergency services and the requirement for an ambulance. I think it further demonstrates the added value of clinicians within the assessment process and how they can safely risk assess the situation for patients such as Jane in this example. And I'll take questions or comments.
Thank you. Louisa, did you want to say something, or is anybody? Yeah. So I thought I saw your hand.
Yeah, no, my hand was up. Okay, so your assessment of what the paper's about actually is interesting, because it's not the take-home message that I got from the paper. And so I thought this was a paper primarily saying that when we move to 111, there will be patients who we currently deal with and understand they have mental health issues that 111 won't, and they will discharge ambulances.
Correct.
And so I felt that if we were going to write a paper that addressed that issue, it would be probably a different sort of paper that would have sort of numbers in it and would be just a very different sort of paper. In a way, this paper felt quite sort of unfamiliar to me, in that it was quite sort of service-centred, not really patient-centred, and I sort of felt quite uncomfortable with some of it, and particularly some of the tone of it. And also, I think a lot of our papers now, that they're very sort of they're very clear, and this felt to me very long-winded, really, and I couldn't really sort of work out the points it was making. But I was concerned that it was service-centred, not patient-centred, that it was really a paper about how we had reduced a person using our service without really anything which is so characteristic of us normally, and why I sort of feel, so proud of NHS Direct, that we see it very much from the patient's viewpoint and trying to make the person using our service feel better. And I had no sense of this, whether she felt better. I thought maybe we felt a bit better, but I wasn't sure she felt better. There was something within the paper I was concerned, for example, in her past clinical history, that we say the GP succinctly summarises her current position and then says Jane is no longer able to present herself to the hospitals of Southern England, but she has discovered the telephone. And it's that sort of thing that I think is a shame when doctors write like that, which is sort of making a bit of a joke at a distressed patient's expense. And I think we really don't do that, and therefore to include that in this paper in a way that looks like we endorse that, I think doesn't reflect well on us. So I suppose I was surprised by the paper. I felt that there really is a issue, because our mental health service, we've all heard calls, it's incredibly impressive. I mean, I think it's something we're really good at. I think it's a service that many CCDs have no idea that we deliver, and we should be really sort of proud of that. But I felt this paper didn't do that service justice, didn't address the issues of how this is a real potential problem for 111, and I think also didn't really make me reassured that we'd done the best for this person.
Okay. Yes, Nick.
Can I just pick up the first point that you made in terms of picking up the implications of frequent service users or high intensity users in 111, and that was the subject of a meeting that I had with Jackie Jezereski, our mental health lead, and Mike Beak, our 111 product manager, and we met with Dr. Hugh Griffiths, who's the National Clinical Director for Mental Health Services, and went through precisely, I think, what you've described, which is just trying to get a scoping on the numbers of such patients and and discussing in qualitative terms the potential impact of 111, and I think that was a very useful conversation.
I didn't mean to be sort of hard on this. I think I came across
but I don't think that was the purpose
than
of this
I meant.
paper. Yeah.
But I just think that's the paper that I suppose that's the paper I want to see.
Well, I'll happily send it to them.
I don't need to see it, but that's the thing.
Peter.
Yeah, I mean, I do understand what you just. It didn't strike me that way.
No, it's interesting.
In social care, there are people like this who have a similar orientation towards using services inappropriately. I'll put it that way, from the service side's point of view, not their point of view. And that, I think that's what you're saying. It's more, I mean, the sensitivity around the patient or the client's perspective of where they sit with this. So I was, because I hadn't thought about it as a whole system problem in the sort of way this approaches it, which I thought was good. The key thing was, I mean, I did see that the patient was at the centre of the conversation. I don't know, we didn't get any flavour of what they thought of the outcome, other than I think I got a sense that the patient seemed to settle down with what they were given, as it were. I don't know if it was given or offered or how it was negotiated, but their call or the way they acted, their outcomes were to settle them down in some ways. Whether that was good or not, I don't know. The issue for me was about people like this and their position regarding the overall priorities of a system, how you treat them, what time you give them, how much emphasis you give them, having done what they've done here. This to me was about it's slightly sort of not compassionate, but it is compassionate, because it's looking at the way we operate in an effective way, but also having a process for these individuals. So I thought that was useful to understand. I mean, in complainant terms, you get vexatious complainants who, in the end, don't get a service because they're seen to be a nuisance. Now, I don't think that's what came over for me in this paper, so I don't think it was quite down that road. But I can see that it needs quite careful understanding of the individual's needs to make sure you don't push them out of the system, so that when they do have the proper requirements, that they are treated as a nuisance and not as a person presenting with a new condition or a new requirement to be treated. I think that is a very difficult balancing act to get right, which this paper, I think, probably didn't quite go into in a bit more detail, but it certainly touched on it.
Yeah, and I think that's absolutely, I think that's absolutely true. So that, because obviously if there are too many people using the service this way, we can't deliver a service to other people. Yeah. So to say we ignore that is obviously ridiculous. I suppose it's the balance. Like you, I think the balance is probably skewed a bit.
Trevor, do you want to? We're going to make yours the last comment, then I'm going to say something, and then
I don't want to drag it out, but I must say I reacted as Louisa did when I read the paper, and I thought Peter mentioned the word vexatious call. You do get vexatious requests into the NHS, but I didn't feel there was anything at all to indicate that Jane was vexatious. Jane has a clinical condition.
Correct.
And my view always has been that you don't get inappropriate requests to the NHS. What you sometimes get is inappropriate responses. And I think I would rather the paper hadn't focused on the number of calls per day, actually focused on how you provide appropriate care to an individual who presents with these type of conditions.
Thank you, Chair. I have to say that I am mostly extremely proud of our service. This wasn't a proud moment for me. I also looked at the letter that we sent to Jane. Made me feel even more uncomfortable. I'd like to have a conversation offline about it. Because like Louisa, I felt we didn't really have any data that helped us understand to what extent this is a problem across the service. I mean, normally, very often you would take an 80-20 rule and you'd say 80% of demand is caused by 20% of people. Now, clearly that's not the case in our service, but it didn't help us really understand what that was, what the real impact was on a wider scale. And I had real anxieties about how well we'd served this individual, this distressed individual. So I'd like to, and anybody else who would like to be involved in that conversation, I'm sure Tricia would welcome them in. But I think there's more to be done. Okay, and I'm sure Tricia, you can circulate the letter to people. Okay, thank you.
Excuse me. Just before we do, there's a general point really that struck me. Is 111 I assume we have a number of complex cases. Is 111 not ideal for complex cases? Is that something that we're trying to imply?
111 the purpose of the paper was to show how we'd worked within a multidisciplinary team. So the request to manage this patient's high usage of the services was brought about by the PCT. We contributed to that management. The paper is also identifying the skills of the mental health team and how they are able to support patients with mental health problems within our current service, and how that may be lost in the future of a 111 service.
So is there a general action that we need to look into?
Well, I think that was really picked up by Nick in his conversation with the...
That's already been picked up.
But I think, I mean, there is an addition to that, in that it'd be interesting to know what real data we have around this, because this was an anecdote. Nick's had a conversation about, sort of at a more strategic level, you know, there's questions around, well, what evidence were you able to present, Nick? And I don't think that's a question we should answer now, but it's something that other people may be interested in. Louisa?
Well, just a small point. I'm not sure how complex her calls were. One of the things seemed to be that because she phoned up breathless and short of breath, it went ambulance sort of straight away. And I suppose it's how a service would be able to pick up
respond to that. Yeah. And that's a very good, I mean, that's a very important question for 111. It's a question for our service, obviously, that we really struggled with. And whether we got to the right place or not, and how we got there is, you know, something we could explore some more. But not now. Thank you, Trish, for offering that to us. I think that it's an example of where one patient can provide a can opener to some really important issues for the service. Okay, so we're reaching the end of our public agenda. I haven't been notified of any other business. Is there any that anyone would like to bring up? No? Okay. Well, I'd like to take the stage then and to offer some thank yous. So first of all, to Helen Astle, for whom this is her last meeting around the board table. And Helen's done sterling work around some of our less glamorous processes, if I may put it that way. But I think Nick would like to...
Some of them very glamorous.
Right. But I think Nick would like to say a little bit more about the contribution that Helen's made.
As everyone around this table recognises, being an interim is a specialist job in itself. You are, by nature, on your way through, supporting an organisation that's in transition, and whilst you are very much part and parcel of everything that's going on, you also stand apart from it because you're an interim. So I just wanted to say how well Helen had straddled those issues for us to help us through some fairly challenging times, and the work that she's done on risk management, on keeping us solidly on the FT pipeline, and helping us with the corporate design work for the new organisation has been invaluable. So she goes with our thanks and our very best wishes for the future.
So beyond Helen, to whom we should give a very warm round of applause, I'd like to thank members of the board who have contributed all year, and really importantly the wider organisation in the front line. I mean, it has been a really tough year this year. It began with a bang with the winter pressures. It's been tremendously challenging for all sorts of reasons. We are a service in transition. We are dealing with we're dealing with the implications of some decisions that have been made a long way from here. We have and are putting a massive amount of work into understanding how we best can contribute in the future world. That work is ongoing. We're learning more each week about what the world might want from us. I don't think it's going to get a lot easier in the next year, frankly. Our cup runneth over with challenges, issues, demands. I've been proud of how the organisation's worked around these things and the way that the board has pulled together. I wish everybody a really relaxing holiday, apart from the people in the organisation who will, as ever, be doing a brilliant job looking after patients and the public, supporting other NHS organisations over the holiday season. I wanted to ask Keith, I mean, we generally have a question at this point about how to manage visits. The those of us in this part of the organisation often like to express our gratitude and support for staff that are working over the holidays. Tim has a tradition of taking tins of biscuits out with him. Perhaps in the private session we might just talk about whether that would be welcome. We obviously have to balance distracting people and showing our support. Nick, I don't know if you want to say anything as we're ending up. If not, we will close up the...
No,
we're happy to.
I have well, wish everyone a happy Christmas, obviously. But bar humbug.
Thank you.